Hello, welcome. I'm excited to go through with one of my colleagues, Chris Wolfe, and we're going to talk about why we even bother with this in the first place. We're going to go through some case examples, and we're both kind of on the same page. If you have questions, drop it in the chat or ask along the way. It's kind of easy, I think, to ask because we're all in the same mindset on the same slide. So I practice in Wyoming, Pennsylvania. We've had RETeval for a long time now, since July of 2022, so 4-year anniversary. But we've just expanded it more and more with what types of patients we use in our practice, and I have ophthalmology referring to me on a regular basis because for whatever reason they don't want to bring this device into their office, but they also find the value in it. I'll let Dr. Wolfe introduce himself because I think that's the next slide. I think you're muted still.
Okay, I'm muted. I'm unmuted. Thanks, guys. Thanks, Amanda. I appreciate it. Amanda's always looking out for me. We've known each other for a few years, and she always kind of saves my bacon. Also, the other thing that you should know is she's a really great clinician. So a lot of times when we're up here talking to a lot of people, it's kind of like, well, are you really in clinical practice? I'm in clinical practice. Amanda's in clinical practice, and she is a rock star. If you don't know her, it's going to be exciting for you to listen to her tonight. I'm in a comprehensive practice, and what we'll try to do tonight is boil down some of these topics related to diabetes, retinal diseases, optic nerve diseases, in a way that's really applicable to what's commonly termed primary care practice, but or comprehensive care practice. And so I'm excited to get into it with you. And I'm excited that Amanda's on here today because I will learn a ton from her as well. So probably to get everything started, I think a helpful thing to think through is I like to think about our profession as how much kind of clinical application and very accurate clinical tools we have to be able to differentiate and diagnose different ocular diseases is really astounding, in so much as it is impressive that we can do that. You think about other professions, like I always liken this to like my family medicine doctor or an internal medicine doctor. And if they want to know what's going on in your heart, they can't, it's very difficult and very challenging and very cost prohibitive for them to actually image a heart. So what do they use? They use functional testing to do that, to give them information about what's going on in terms of a differential diagnosis in the heart, for example. Well, we oftentimes will defer to structure. Everything becomes structure as we kind of evaluate different things. And often, in fact, very often, we can differentiate what we're managing clinically by the structure that we see. Sometimes we need to know more about that structure. So, we might start out with sort of a standard image. And then as technology evolves, we can get larger images, wider images. And then we can also kind of go deeper. So we think about going broad, and we can go deep in terms of really getting high resolution images. And as I said before, oftentimes that will answer the question for us based on kind of our differential of what we're seeing. But sometimes it can't answer the question fully. And also both in terms of differential diagnosis, as in what's the problem? I know Amanda's going to talk a little bit about, sort of using this a lot in patients where they have sort of murky symptoms. But also it helps us differentiate between patients who may be progressive or patients who may be suffering from a disease that we can't necessarily detect on 20/20 acuity or color vision or even easily detectable on a visual field. And so that's kind of what we're talking about tonight is okay, well, we talk about structure. You guys have heard about structure a ton, but this discussion really talks about how function can play a role into our very advanced structural evaluation. So I'll ask you, and you don't have to answer right now, but you can definitely chime in, is do you think testing structure and function in pathology is important? And I think largely what we're going to talk about tonight is related to this question. And so I want to start by kind of presenting a case in terms of thinking about specifically diabetes and specifically thinking about what our clinical practice guidelines and preferred practice patterns recommend we ought to do with a patient who has early diabetes. And the fact that some of those patients, there are differences in how those clinical or ophthalmoscopic findings are likely to impact that patient's risk of progress. It's hard to differentiate just based on looking at the eyes. And so that's what we're going to start with. So if you think about prediction in patients who have diabetes, I've got a couple images here, and I've blown these up so that you can see a few things. I'm going to point them out. If you're looking on your computer screen, you will see these now that I've circled them. But here's a patient that has a couple microaneurysms. I've circled them here for you, and they're super tiny. And by the way, if I didn't, I'll tell you, as good of a clinician as I think I am, I probably would have a hard time identifying these on my ophthalmoscopic evaluation, even my stereoscopic dilated ophthalmoscopic evaluation. So this is kind of a testament to being able to use higher or newer technology to evaluate that structure, as we talked about before. I would bet Amanda could detect this ophthalmoscopically, where I would be not quite as good. So this is So this is one patient, and this is obviously this patient's right eye, and I want to contrast that. So again, Amanda, as we're thinking about this, and we look at ETDRS, we would classify this patient with 2 microaneurysms in one quadrant as mild diabetic retinopathy. That patient had diabetes. And so, clinical practice guidelines would recommend we'd probably do a deep dive, at least probably annually on this patient, unless they had significant risk factors. Maybe if they had a really congested nerve and we were thinking about GLP-1s and perhaps that patient is at a risk for NAIONs. If you look at some of our AOA white papers on it, we may want to touch base with those patients more frequently. But the bottom line is just based on ETDRS and risk for sight-threatening vision problems that can arise from progression of the diabetic retinopathy, we would think, okay, we're going to watch this patient in a year. And if we look at the next patient, so this is another patient, and if we look at this patient, again, very subtle, but you'll see really fine blot hemorrhages, and you can see these. Hopefully, you can see these on your screen that I've circled here. Again, I think this is a testament to the technology that we have available to us. And this patient would also be a separate patient. This is the left eye, but it's a separate, different patient. It's not the exact same patient. This patient would still be classified as having mild retinopathy. And then the question becomes, if we just use our clinical practice guidelines or our preferred practice patterns, and then we utilize ETDRS to inform our decisions about how we should monitor this patient for risk of sight-threatening conditions, both of these patients we would see would be the answer to that would be annually. And if we look at kind of deeper to see, can we get any more information? Let's say that we look at OCT technology and we see some macular edema in the right eye. That's going to absolutely change our course for the patient. So this would fall under now, and you can certainly chime in if you're thinking differently about this than I am, Amanda. But when I look at a patient with mild macular edema in 20/20 vision, my mind immediately goes to Protocol V. And as you know, Protocol V basically tells us that we don't necessarily have to treat all these patients with macular edema who also have good vision. So now I might say, well, based on that, I may follow up with this patient a little bit more frequently, based on our clinical practice guidelines and based on ETDRS. And so, but if you look at their A1C, it's pretty good. They're young, they got a lot of years left. And so I'm not going to let them, their macular edema just sort of sit. So then we take the other patient and, it's an older patient, mild diabetic retinopathy, same visual acuity, very mild macular edema in the other eye. So, my clinical intuition, I don't know about you, Amanda, when I see these patients, first you can see the A1C is pretty high. But all the clinical picture outside of the patient being older is effectively exactly the same. Even with Protocol V and 20/25 visual acuity, we can still follow Protocol V. And Amanda, I'm going to pause here because I want to get your impression. When you see a patient with 20/25 visual acuity or better, and mild macular edema, meaning not clinically significant macular edema, meaning it's only detectable on OCT. That's what Protocol V tells us. It informs us how we can follow these patients. I would probably cut that in half after I've established stability. So in my mind, I would say, okay, I would typically see this patient if they had no macular edema, mild diabetic retinopathy. I'm going to see them in a year. But if they have some DME, but it's not clinically significant, only detectable on OCT, still good visual acuity loss. The short-term thing I'm going to do is I'm going to follow them in 3 months and prove that macular edema isn't progressive. So I'd usually go 3, 6, and then every 6 thereafter, because they're at a higher risk for that visual acuity loss. I'll pause there. Amanda, do you want to chime in? Any other thoughts? Am I going wrong someplace?
No, exactly the same. I like that 3-month interval. I don't like anything that's at risk for changing their vision. Not every patient is even good at detecting, early metamorphopsia or changes from this mild that they are asymptomatic of now to, potential early progression where maybe they're like 20, 30 and mild, metamorphopsia. I don't think any of us, maybe we should, but I don't think any of us are handing Amsler grids to our diabetic retinopathy patients. So from that perspective, but I absolutely agree with you too, is like, I got to prove stability to myself. If this is a brand new patient in my chair, okay, this is a snapshot of day 1, but I say this all the time when I lecture, is like, one person in your chair can do anything. I love the stats. Yeah. We need the studies. We need to understand how we drive big picture decisions in medicine, but out of hundreds of patients in a study, that one individual does whatever they want to do. We're just statistically making the decisions about it at the end of a study that way. So knowing that, it's like, let's go. I think 3-month interval is reasonable. That's what I would do too. If it's like the same or even a touch worse, like another 3 months, once I'm like convinced it's the same, or sometimes these get better and disappear, and you would never know it was there unless you ran the OCT in the first place, and then start spreading it out from there, for sure.
Yeah, and I think you're absolutely right. And I think this is where this technology, now we sort of have ETDRS, we've covered Protocol V. They were saying, okay, they both fall under this. Should I be more concerned about one versus the other? And that's where I think ERG specifically can come into play. And so if we look at both these patients, one is the right eye, one is the left eye, that's an impact. So can I know more information about what their risk of progression is based on how their diabetic retinopathy, their DR assessment, ERG is going to inform me? And the answer is yes. We have a study, and we've cited it here for you, is to say, okay, listen, their risk for vision loss, so vision-threatening conditions related to diabetes, is basically 0 over 6 months and 0 over 1 year if their DR score is 19.9 or less. Okay, so first, it allows me to super simply get information based on color coding. And then second, it allows me to sort of stratify the risk. So now, if I'm having a conversation with this patient, and let's say, Amanda, that I missed my ERG at the first visit. Maybe I did my OCT. I see that the patient falls under Protocol V. I follow them up in 3 months. It's exactly the same, and I get a DR score of 19.9 or less. I'm probably comfortable going another 3 months, and then another at that point not changing. We're going to go 6 months, and I probably see them every 6 months, and as you said, just kind of monitor over time. But if I see that patient back in 3 months or 6 months later, and I start to see this number that's in the yellows or the reds, I'm probably following up with them every 3 months. And I'm going to stay with that course, because the reality is, 1 in 2 chance. So let's say 26.9 or greater. I have a 1 in 2 chance of this patient over the next 6 months of having vision-threatening retinopathy from their diabetes. That's a huge ability for me to modify what I'm going to do for this patient. And the bottom line is that it allows me to serve the patient better. So if they do convert into having vision-threatening problems, we're right there, and we can help them. And so that's why I think this is so powerful. So the question I will ask or I'll pose to people, and we sort of already did, is, does this structure, do we want functional information? And so let me show you the outcomes for both. So if I were to ask you, actually, I'm going to ask you, Amanda, you probably have looked at all this. You probably looked at all this. Okay. I'm not going to ask. I'll just ask the question.
I looked. It's not fair.
You looked, okay. So if anybody wants to chime in, we'll say patient 1 or patient 2, who's more likely to have progression? You can chime in on the chat. I think that'd be kind of interesting really quickly. So I'll maybe give you like 10 seconds if you wanted to put patient 1 or patient 2 and vote who you think is going to have the worst DR score. It makes me actually think, so here's your answers, and it makes me actually think a little bit more about, do we know more information actually, Amanda? And this is interesting. So the bottom line here, before I get on to the next point that sort of as my mind wanders here, is, okay, so the patient on the left, I'm much more secure in saying, listen, once I know that DME is not progressive, let's watch them every 6 months. And I'm totally comfortable with that. On the other side, if that patient number 2 on the right-hand side of your screen, this patient, I'm probably going to see every 3 months, either until that DME resolves or we start seeing an improvement of this DR score over time that lessens my concern about their risk for progression. And so I think that the interesting part for me, and we don't know the answer yet, is I mean, what it has me thinking about as I look at these 2 patients clinically is there something about a patient who develops microaneurysms that is actually less severe than the patient that has blot hemorrhages? I don't think we know that yet, but I do think that some information is coming. And so again, this is just an interpretation guide of what we've already talked about. But I think that question is something that we're going to know a lot more about as we can be better at testing some of these patients and incorporating some of this new technology into sort of our standards. So just like you and I have talked about on the podcast years ago, Amanda, is this idea of what's called non-ophthalmoscopic macular degeneration, maculas and retinas that aren't functioning well, but they don't have any ophthalmoscopic damage. You wouldn't know by looking at their eyes. Is some of the newer research that we're actually pouring and developing resources into that is being done right now that you can see on this screen. Is that research actually going to show us that, yeah, maybe microaneurysms aren't as concerning as blot hemorrhages, or maybe we don't even care about any of it. Maybe we just care about retinal function first before we see damage and bleeding on the retina. So super interesting. I don't think we know the answers to it yet, but from my perspective, I think that's very helpful. And this can be a super helpful tool in helping us differentiate that both in our current clinical scenarios and as research evolves and we get better at detecting things, maybe we'll find more information. And so I think the thing about this, and you can see this on the screen, the thing about this that helps me is like it's super easy to use. Once your team is trained on it, and once you understand how to interpret it, both with color codes and then also with just numbers that you'll get more and more familiar with, just like you look at your OCTs, it becomes easier to use. And so I think the bottom line from my perspective is, in this case, it really helps me assess function, where a 24-2 or a 30-2, presumably I would get some information about a 10-2, but the most important part from this standpoint is the ability to predict progression based on evidence and studies that can help me inform that. And so before I hand it off to you, I think the key from my perspective here, and what I want to sort of transition, Amanda, into your case or your next case is, okay, how do we think about this in terms of detecting? Yes, we're talking about diabetes, but detecting, what types of diseases impact the retina, uncertainties that exist within glaucoma or optic nerve diseases, and then how does that allow us to predict and manage patients over time? I think that's the key. And so I'm going to kick it kind of over to you, because we talked about diabetic retinopathy, and we talked a little bit about sort of the slew of, everybody wants to know, like, diagnosis codes covered. My response to this, before I kick it over to you, Amanda, the last points I will make is, don't just use, and maybe you and I could talk a little bit about this too, but don't just use this because you have a billable code. That's where I think a lot of docs go wrong, is they start by saying, what can I bill this with? What I think is better to think about, and I'd love to hear your perspective related to your cases that you're going to go through, is what what information do you want on the common conditions that you manage that you don't otherwise have information about? Or what clinical conditions do you encounter, symptoms and signs that you're uncertain about that you'd like more information? So with that, Amanda, I think I'm going to kick it over to you for the next few slides, talking about diabetic retinopathy kind of more broadly. Is that all right?
Yeah, I'm like, this is why we're friends, because I love what you said is like, order it because it makes sense for your patient. Like, yeah, we can talk about, revenue all day. I live by the mantra, like, what's good for your patient is what's good for your practice. I don't think we have to push every test on every patient and we're going to have a big capture rate. If we are good at doing our job, you're going to have a good capture rate and reasons to do this. That will, because the only thing that matters to me at the end of ordering a test or at the end of my exam is like, what is this doing for my clinical decision making? If it's nothing, even if it seems like I've been in practice long enough to see some like cool, exciting things come up, and we are on board and we're doing it, and then we realize like over time, months, maybe a year, that it's not changing our clinical decision making and it slowly fades into the background. I can tell you very much the opposite. My experience over these 4 years, all we keep doing is using it more and more because it reinforces us every time that it matches and helps predict, and just that one extra piece to the puzzle that you might need to make that good clinical decision, that it's just built up of how we use it in practice is great. So diabetic retinopathy is probably the most common thing that I use it for, but let's talk about diabetic retinopathy. I loved those two cases initially because they were so subtle for us to find. Like that exists all the time, in our patients, these tiny microaneurysms, a single blot heme that's out there. But if they, they have diabetes, they have other, comorbidities, I'm sure come with it. Like that's a sick retina. We shouldn't have, I know we call these idiopathic hemorrhages once in a while that come up. And sure, but one of my favorite professors at optometry school always reminded us that if it's idiopathic, means the doctor's an idiot and didn't really know the underlying cause, or we're just not there in technology, yet in the scheme of things. But it means there's something abnormal, because that shouldn't necessarily happen. So we have to get good at being clinicians and diagnosticians in order for this stuff to serve us too, because the earlier we find disease, and retina, I talk to my patients all the time. Why am I so concerned about this? Why am I ordering an extra test? Why am I seeing you every 3 months? Because your retina is brain tissue, which means the cells that we're born with are the cells that we got. So if we can catch things early and preserve and keep your good vision, that is our best case scenario. Chasing disease, you have vision loss. Now people have complaints. Like I just never envy a retina specialist job to do like injections when somebody has really advanced macular edema and they're doing injections for months, or maybe some focal laser, and it's still not 2020. And I'm like, I know it's been so advanced and the retina's so thick, like those cells are just not, they're either not there or they're just never going to work the same. So this idea of early catching and prevention and the functional is just one other piece to be able to let us do that really well. So the DR score, we talk about a lot. It's great because we got statistics with it and it's color coded. It reminds me, because it just started being color coded recently when I age myself, when like GCC analysis first came up, and there was no statistical, it wasn't color coded. So we had to look at normative values and make decisions, like really learn the numbers. So to some degree, I'm thankful I didn't have this color coding as I was looking through and learning this in the very first place. But I am really happy to have it and understand what's going on for patients in the future. So what the DR score is meaning to us is that we have implicit time, which is the time it takes the retina to catch the signal of the light and send that to the retina, or send that to the brain, I'm sorry. That if the cells are sick or under stress, that time starts to slow down often as our first cue. And then it also measures the amplitude, like how much electrical activity is there. So now if the disease is progressive, you're actually having cell loss, there's less overall cells to make that signal, so the amplitude starts to decrease over time. Now, with all of this DR score, we've proven that it really makes differences in how we can have clinical decision making. So going back to this study, it is a decent amount of patients. All of them had like moderate to severe NPDR, because it's no surprise that if you have advanced structural damage, it's often going to match advanced or changing functional damage, but those two things are not perfectly paired with each other. So out of all of the patients and looking between the RETeval, which ERG, color fundus photography, OCT, and even ultra wide field fluorescein angiographies, it's the RETeval that was the most predictive of what could happen in the future. Chris, if you want to jump to the next slide.
Yeah, and as you go to that next slide, I would say just if I were gonna guess on that, like I would not have guessed that, right? We're so aligned with structure that if you would have asked me this question, in fact, I did ask this question to an audience a few months back of what would I think is the strongest predictor of progression structurally. I would have probably not, I don't know, I think I would have probably got the OCTA correct. But if I would have asked the whole question of which one is, whether it's structure or function, I would have totally gotten it wrong. I would have not seen the power. I would have not thought, even as I've used this for years, I would have not thought that that would be so powerful, which is why I talk about, like, maybe in the future, that's what we're going to be using as an early detector.
Mm-hmm. Yeah, agreed, totally. Like OCTA is really exciting in the microscopic damage to the vasculature it's causing in diabetes, but the function, wins. And we'll go back to our conversation years ago about macular degeneration and, dark adaptation. Like the function wins and is more accurate almost every time. So I have a different take on function because that's what I just came into practice, like learning and realizing and knowing. So I'm kind of spoiled in that regard, but it's just so important for understanding the patient's total picture. And I haven't found more information to ever be a bad thing.
Yeah, sorry to interrupt. Keep going.
Yep, you're good. We'll flip to the next one. All right, so that's how we're going back to this. It was based on that study and then being able to calculate this DR score, again, kind of based on the amplitude and the implicit time. Also, the patient's age is taken into account and just like how crisp and reactive their pupillary function is. I explain it to patients that it's like, you can get neuropathy, in your fingers and your feet. It's kind of like that to the iris. It just slows down. It's not as reactive as it is. And so that's like another piece of information that we're calculating into this final, what we're calling, the DR score. So it's not just the waveforms. There's more information, interestingly, than that. And then we can really get some good information about how worried we need to be about our patients in a snapshot as this one time, or what my cases are going to show is like the importance of seeing what happens with that one patient of yours over time. Flip to the next one. And so the point of that, which we'll go through, is like, so great, you have a snapshot, you're going to decide to see them back in 3 months, 6 months, or a year. Well, it's worth repeating that, right, over time. Why is it worth repeating it? Because not only do we know in a single snapshot what the DR score represents, but now if we're looking at one individual person and their potential change over time, we'll look at this like risk of intervention that's needed. So what does risk of intervention mean, right? It's either like diabetic macular edema, we're talking about focal laser, we're talking about injections, we're talking about PDR that needs some kind of actual medical intervention here. So with a 3-point increase, so, that person is 18 and now they're 19, 20, 21-ish, doesn't look that bad, but look at a 3-point increase in that DR score, it doubles their risk, that individual patient's risk compared to what they were last year. So each 1 point increases that relative risk by about 28%. So it's also really sensitive in that small changes mean big potential outcomes. Do you have anything to add about that, Chris, before we go on?
It just comes back in my mind, Amanda, to just individualizing care. The thrust for most healthcare is taking. If you've heard me talk recently, I've sort of almost feeling like every talk I've given over the last few years talks about evidence-based medicine. And what we often get confused is evidence-based medicine is not just the preponderance of a pyramid of evidence where we think about a randomized placebo-controlled trial on top and then a case report on the bottom. It is, and that's all evidence-based medicine is. It actually takes into account 3 overlapping circles. One, which is the research, that we're talking about, like the pyramid of evidence. The second one is what I call clinical hunches, but what they proposed 30 years ago with evidence-based medicine is clinical insight, clinical intuition, basically, like being a clinician. And that's what you've talked a lot about, and you do a ton of that, kind of being a clinician. And the third part that we all forget, but it's so important from a comprehensive care standpoint, is patient preference for treatment, right? So those three circles overlapping, that overlapping spot is evidence-based medicine. And individualizing your care. So saying that study, and then Amanda thinking, okay, Mrs. Smith, you've got these problems. And also, I know that I'm individualizing your care because I'm not just following clinical practice guidelines. I am, but I'm also tailoring that because now I've seen that her DR score has gone up 3 points or 4.5 points or 10 points. And now I'm individualizing her care, which better manages her preference for, perhaps she doesn't want to, be as tightly controlled on blood sugar. I don't know. I'm just saying, like, there are ways for us to tailor all of that to what we're seeing clinically, and that's how this helps. Sorry, that's a long-winded answer, Amanda.
No, it was a great discussion because I agree. This is individualizing healthcare on just an excellent level that I'm so excited about. So we'll move into, I think we've convinced you enough as to why it is clinically proven and why we would like to use it. But let's talk about some like actual cases. And this again is more, we'll see the snapshot. I don't think it'll be shocking or have to tell the difference, but it's going to show you how our eye chose to manage these patients. So they're a married couple. They're funny. They're like, 45 plus years marriage, like to just chatter and kind of argue with each other during the exams. And they both have diabetes, but they both have a very different history with their diabetes. So the first one we're going to talk about is the wife. So she's 72, white female, of course, has your typical diabetes, high blood pressure, cholesterol, on the medications because of that. And her most recent A1C that she knows of is 7.5. So not ideal, but that's honestly like her norm. Like she has always, I don't think she's ever been below 7, like as long as I've known her, for 15 years. So she has a history of cataract surgery, and she has a very long-standing history of proliferative retinopathy. When she became my patient, she was still in treatment for it. Again, this is like 10 years ago. She had a multitude of anti-VEGF injections. She had extensive PRP, I'll show you. But for the past 5 years, prior to, I believe this is 2023, so before that, she hadn't needed any treatment. We'd stopped everything. She wasn't even really with the retina specialist anymore, kind of released unless I see changes to send them back. So I'm interested in seeing how she might progress. I'll show you her DR score. Now again, when I show you her PRP and the scoring, there's no surprise that her ERG is going to be terrible, right? Because it's a full field ERG. So if you have a ton of PRP, you've killed off purposefully.
Yep. Did we lose Amanda?
I'm no longer muted.
Good? You're good. Yeah, you're good.
Okay. So it's not going to be any surprise with all of her PRP, her retina is dysfunctional. But with this abnormal, DR score, high of 24.5, so that doesn't panic me in one snapshot. I know her history and things are not changed for her. But I've been seeing her every 6 months and, just wondering if this is going to change anything even honestly further than that. So, look at how much PRP she has. She has a lot. Which is good in some ways. I've seen good PRP hold off, proliferative retinopathy for years. Cross your fingers, maybe forever. But she still has 4 quads of dot and blot heme. She's got all kinds of vasculature changes that you can see, narrowing, nicking, microaneurysms, the classic ones. If you go forward, because I think and then just to show you her OCT, there's no macular edema. She has a lovely ERM in the right eye more than the left eye. There are some central microaneurysms you can see at the level of the IPL and the on-FOS imaging, but mild. You can flip to the next one, I think is her OCTA, which also not unexpected, definitely some capillary dropout, like more asymmetric, more in the left eye compared to the right eye, and both of the foveolae vascular zones are asymmetric. That's been pretty stable over the years. So that was, the initial ERG was in 2023, and now I'm seeing her, I saw her 6 months, and I saw her a year later. Now we're into 2024. So like, what is happening with this, patient over time? So it actually improved, a little bit. It's nothing significant that from the DR score, but when I'm eyeballing this, like the DR score is obviously important. When I'm eyeballing this, there's the waveforms that you can see, and there's two like tiny vertical kind of boxes, and that's your little statistical normative value for both like time and amplitude. It just sort of spots. You can see like the waveforms are sick. The left eye is a little bit sicker, less than the right eye. But the fact that she is the same compared to her in the past, knowing that the structural damage is obviously the same, the PRP is not progressive or changing. So it really is giving me a good snapshot of this individual patient, that she's pretty stable, even though she's really abnormal. So we've kept up the every 6 months monitoring for her. But her husband's kind of interesting. I think I just said all of this. Hi, Amanda Sam. Yep. But her husband, interestingly, he's similar in a lot of ways, where he's 80, white, male, diabetes, high blood pressure, cholesterol. He also has some early dementia, but A1C kind of the same, right? 7.4-ish was his last one. But that was about 2 or 3 months ago. And since then, his Mounjaro medication was on back order at the time. This was back in 2023 when it was kind of hot stuff and flying off the shelves. So he hadn't had it, and his sugars were going up to about 300 at a time, that he was a little bit panicked. He knows exactly what his wife went through the many years, what her vision is now, and wants to avoid it, kind of all costs for himself, hopefully. He's also had cataract surgery. Nothing really remarkable with his retinas or vasculature. He does have tiny, like pinpoint kind of drusen in both eyes, but overall, nothing that I'm concerned about. Same thing, OCT, tiny drusen. There's some, floaters in there blocking the images of the en face a little bit, but nothing significant. Certainly no macular edema. I don't see any like small changes with the with any microaneurysms. So I feel pretty good structurally, about him. But again, we know his sugars were up to 300 plus recently, and like kind of consistent that way as he's waiting. He has, because of the dementia, he has less of a great scan of his OCTA. You have to hold pretty darn still for these to have a great image. So there is some asymmetric foveal vascular zone. There is some capillary dropout. I don't trust this test as much as I did his wife, but that's what we found that day, just for completion's sake. So we did the ERG, and it was great, thank goodness. So 16, way below the concerning value if you're looking at like 20 and above as your little alarm system going off. So he had a normal DR score of 16 in that 2023 year. You can see, again, if you're looking at those small statistical normative, those little boxes in the waveforms, there is some asymmetry that the left eye has a little bit higher amplitude compared to the right eye. But, overall, both pupils are reacting well. The waveforms look great, and his DR score is excellent. So that was really reassuring. But I did, you're not just taking function into account. I did see him again in 6 months as well, since things were fluctuating. I will tell you, he was stable at that, and he went back to once a year, ultimately. And I just said all of that too, because I talk about all of them. Yep. So these are just the codes that I use. So, and this is kind of important. So for the wife, it was diabetic retinopathy, is nothing that's concerning. For the husband, I use the code H35013, which is retina vasculature changes. He does have some really mild, like AV nicking, and some of the narrowing that you could see of the vasculature, really mild, but it was there enough, and we can see it on the OCTA. Even if it's not reliable, it's there. So I felt comfortable using that code for him. We did fundus photos. You can do photos or OCT with the ERG. Certainly we can't do photos and OCT together, but you can do structure and function on the same day. So that's a great time to do it.
Great cases. Awesome.
I didn't have to refer any of them. Yeah, really interesting.
Yeah, that's awesome. Yeah. Well, so I'll kind of transition that into, this, we talk about retinal vasculature. I'm going to talk about general retinal health. And I think the kind of simplest way to think about kind of a waveform, you probably know Nate Lighthizer. Nate and I go way back. He did his residency in Oklahoma the year after I graduated, and and he is like a wonk on VEPs and ERGs, really electrophysiology. Well, the reality, Amanda, as you know, is that Nate's a wonk on everything. The simple form for me is I just want to know, like, what is this telling me very easily and very straightforward? So this helps me a ton to think about a sick retina is going to be delayed, right? The response that I'm going to see is going to be delayed if the retina is sick. And if the retina is dying or dead, or there's cells that are dead, then we're going to see the amplitude's going to be diminished. And that's kind of the way that it's easy for me. So okay, I'm going to see when the retina is not working very well, we're going to see a delayed implicit time. And if the retina is damaged, we're going to see a reduction in the amplitude of the waveform. And that's an easy way for me to understand it, very simply and straightforward. And it's also an easy way for me to communicate it to patients. And so again, people like to know what ICD codes are billable. Here's a whole slew of them. I would start, and we'll talk about this sort of towards the end, but I would start by saying, which ones do you see often? And then which ones are you seeing often that leave you with uncertainty? So you mentioned one, Amanda, that was really good. It was like retinal vasculature changes. So what you're saying to yourself is, I wonder if these vasculature changes are associated with diabetic retinopathy. Is this actually like a retinopathy problem, or is this just a non-retinopathy problem? We see this all the time when you're looking at ultra wide field images, where you'll see little blot hemorrhages or microaneurysms in the periphery, and you're like, do I really have to be super quick to refer this patient for cholesterol and blood sugar and microvascular disease workup evaluation? Or can I say, listen, it's definitely good for you to go do this, but you don't have to do it in the next week or two. Maybe you have a month or two, or maybe your next primary care visit is 2 or 3 months away. These numbers are good. Your retina is functioning well. This is probably just a Valsalva. It can wait for 2 or 3 months, right? So it allows us to do that. And those are very common scenarios where, it used to be that we're kind of making sure a little bit quicker if the patient doesn't have a diagnosis or hasn't seen their primary care doctor, with any recency. So think about where you want to use this. So this case, kind of my last case, Amanda, I'd like to share is how do we apply this to patients where maybe it helps tell the story better, one, to us, and two, to the patient. So this is a patient that I saw. She's an 83-year-old Caucasian female. She had some changes in vision, sometimes blurry. Lighting made the most impact. She had been treated for high blood pressure. She had had cataract surgery, and what we see with her retina is just very mild dry macular degeneration. Now, with these photos, you can see that I should say that on the subsequent visits, she had had cataract surgery. On this visit, she hadn't had it yet, and so you can see some haziness in her retina, which will get better on our post-surgical evaluation. The bottom line is, I'll tell you, I would have probably missed, without an OCT. I would have seen maybe there's a little bit of disruption of the pigment, but the reason I ordered the OCT is because I saw some disruption of the pigment. I didn't know how significant it was, and when you look at it on our OCT, you can see that it's larger than the central retinal vein. So that puts this patient in intermediate macular degeneration, even though it's really hard to tell ophthalmoscopically. So again, I think that's just shows you how helpful our newer technology can be. And so again, you can see that what are next steps? Well, at the time, 2021, I didn't have any functional tests that I could show her. But I educated her. I sent her for cataract surgery, and I talked to her about, ARED supplementation based on her level of macular degeneration. And then she came back for her post-op visits and then didn't come back. She didn't come back for 3.5 to 4 years. And this is how significant she looked different. Now, so if you look at her macula, she's got a couple things that are characteristically popping out for me. Is you see that pigment migration, where we not only have larger drusen, much more large drusen, as well as pigment migration around some of those drusen where we're getting clumping of that pigment. And Amanda, you and I have talked about this, but if you look at some of the post-analysis that they did during AREDS 1 to be predictive of which types of patients are more at risk phenotypically to progress into vision loss from their macular degeneration, this was the big one. Like it wasn't like just a large druse. It was, you got pigment migration. That's like a 1 in 2 chance over the next 5 years you're gonna have vision loss from macular degeneration. So she went from basically intermediate drusen with no pigment clump, no pigment migration to risk for vision loss. Now, on the good side, we look at her fundus autofluorescence, you really don't see any hyper or hypofluorescence in the macula. So she doesn't have geographic atrophy. That's probably the most important thing relative to what's going on today. And no significant hyperfluorescence. Now, that's interesting because I would be more suspicious of geographic atrophy and more suspicious of general progression with hyperfluorescence than with nothing. So if I were just to look at this, I would say, she's probably pretty stable, but I know she's not stable. I know she's progressed over the last 4 years because I've seen it happen, and it was so stark. The point is that she wasn't really taking her medication. She wasn't adhering to her medications, and she certainly wasn't adhering to her follow-up visits. And we're within that 5-year window now. If she goes another 3 to 5 years, she could have significant vision loss that could be longer or more significant because it took so long to get to her wet macular degeneration just because she wasn't being followed close. So again, she doesn't have wet macular degeneration, but the risk of progression to macular degeneration is about 1 in 2 over the course of 5 years in patients with this pigment migration. And I think this is kind of cool. Amanda, you can see my cursor here, can't you? You might be on mute.
No, yeah.
Oh, you can't.
I cannot. I don't see the cursor.
Okay, so well, I'll call it out.
Those
so
hyper-reflective foci in there.
Bingo. Yes. So for those of you watching, you can obviously see that pigment migration that looks like a hyper-reflective area on both OCTs that was not present in the initial 2021 evaluation. So how do I reinforce this patient that it's important? Well, at this point, I now had an ability to say, listen, your retina is not working well. I know that you can still see really well. I mean, you're not having any significant vision problems, but it is important for you to maintain follow-up. We have a test that's called an ERG that's similar to an EKG that allows us to detect how your retina is functioning beyond your 20/20 vision. And so again, this is really subtle, but it shows me that her retina is sick, specifically in the left eye. So what's interesting is in this case, yes, it's a full field ERG. Yes, it's not specifically related to just macular degeneration, but there are patients who have macular degeneration whose retinas generally are not functioning well. And there are patients who have macular degeneration whose retinas are functioning very well. One, they're 20/20 and they're transmitting a signal very well. This patient, the determiner for her to come back, and she now has come back as we have recommended for her, was really the key was, okay, you had progressed, but you've progressed and your eyes are not working the way they ought to work. And that's what allowed me to reinforce that point was both comparing structure, and in her mind, her eyes were working fine until we showed her that they were not. And that's what this was helpful with. And so again, my goal, and as you know, why do we care about the conversion from dry macular degeneration to wet? I often talk about the fact that we can be lulled to sleep as clinicians because our intravitreal injections for wet AMD are so effective. But the reality is studies still tell us that if we can get to a patient with 20/30 at conversion from dry to wet macular degeneration, if we can get to that patient at 20/30, in 5 years, they're likely to be 20/30. If we get to that patient at 2100, yes, in the short term, their vision will be benefited. It'll be improved from 2100 to maybe 2030, 2025 as we resolve that wet macular degeneration. But the studies show me that in 5 years, they're probably going to be 2100. So the whole point is the faster we can get to that patient once they convert, the better. And those patients, I find, Amanda, that we're managing appropriately and also keeping tabs on are way more likely to report problems when they occur than the patients who just only come back when they either think there's a problem because it's been going on too long, or they don't know there's a problem because they just let it keep going.
Yeah, totally. You said something like early on in the lecture that now that you went through this makes me really think what the future holds. So again, this is an aside, but grew up, with the advent and the commercialization of actually utilizing dark adaptation, and we're looking at healthy retinas. You can't even see drusen happening, and some of these people are so delayed. It didn't at all in the beginning make sense, and I'm like, I don't even know if I trust this, because how can you have a perfectly healthy and that includes on OCT was generally fine. And what was kind of evolving almost at the same time was investigation and looking really deep into these subretinal drusenoid deposits, or the pseudoreticular pseudodrusen, and realize that the patients who have those specifically have a really, really delayed dark adapt, and they're really, really much higher risk compared to just, regular drusen. And that's not at all involved in our ARED scaling or anything, because it's newer than AREDS 2 when it came out. So, I started with function. It almost didn't make sense at first. And then the structure and that caught up. And I think the same is happening with ERG, that the more it's out there and the more we're utilizing it and the more we're so with diabetic retinopathy, they're kind of looking at reevaluating the totality of how we grade that condition, period. And ERG is a big part of that. So, function, structure, and looking at all these different imaging modalities that we have at our hands, and how can we put this whole picture together to really predict what's going to happen in the future. But point being, I think function is just so important going forward now, and who knows what the future. The last thing we'll hit on is optic nerve. Go ahead.
No, go ahead. I'll let you kind of take away kind of your thoughts about optic nerve. And optic nerve, as I set you up, I would just say, like, it's kind of daunting for a lot of people, don't you think? And you're sort of thinking, like, especially, I love visual fields. I know everybody hates them. I love them. I just think the more you do them, the better that the patient gets, and the better I get at interpreting whether it's useful information. But it doesn't tell the complete story all the way. And that's where, optic nerve, ERG, can be helpful.
Yeah, for sure. And I tell patients this a lot. Like, optic nerve disease causes weird types of field loss, often a lot before visual acuity loss. And, all we have these patients do every time they're in our chair is read the visual acuity chart, and I will say often is like, we have to do this. It's a way to standardize that if you go from my office to Dr. Wolfe's office, we're talking the same language, and we can judge the same thing as much as possible. But that's not at all the totality of your visual experience, depending on glare sensitivity and poor, dim lighting versus good lighting, and the contrast of things, and how tired your eyes are at the end of the day. It's such a small peek into what their visual experience is, just looking at visual acuity alone. And we know that there's a lot of complaints that don't make sense at all with what we're seeing, and that's a lot of optic nerve conditions fall under that. But as always, glaucoma is always one of these tricky things where it's not one piece that we can diagnose. I will often, again, tell my patients, like, it's not as simple as high blood pressure, where, like, almost everyone has the same goal of 120/80-ish. And if you're above that, you have the disease, and if you're below that, you're good. IOP is such a small piece of the puzzle that we know pressures of 10 can have terrible glaucoma. Pressures of 28 never develop optic nerve damage. And the OCT doesn't always correlate with the optic nerve that we're looking at, doesn't correlate with the IOP. And then, so for glaucoma in particular, having like one other piece that might be like the tiebreaker between all these other tests that might not exactly agree can be really helpful. You can go forward from there. But this is, I'll say this, like vision loss or this non-specific stuff, this is what I get referrals from the ophthalmologist around the area a lot, where somebody's complaining about something, either their night vision, their vision's blurry, we can't correct them to 20/20, can't figure out why. It's like, well, you know what we can do? And there's good codes to go along with, just abnormal visual complaints, is make sure that their retina is intact, right? So the ERG is super helpful with that. In glaucoma, instead of looking at the A wave, the B wave, we're really looking in particular at the PHNR, which is the part of the ERG wave that is pretty specific to the ganglion cell layer. So truly, with the glaucoma testing and PHNR values, we're looking at what the function is of the ganglion cells. And same concept that we're looking at implicit time. If that's delayed, the cells are more under stress. We're looking at amplitude. If that's going down, there's likely to be cell death. And the disease is more progressive in that regard. So we're getting, correct me, those who are on with ERG, is that color-coded now, PHNR values, or is it coming? I can't remember.
I just got a hardware or a firmware update, or somebody said to, yeah.
Yeah,
Yeah.
the PHNR report still does not have color coding, but we do have that new box of information at the top. So we take the relevant
That's
data
perfect.
points from across the report, put them at the top so you can see them all in one place very easily.
Yeah,
I
which is
mean,
perfect because
one of the things, Amanda,
just
is
using your brain and thinking about it.
yeah. Well, I mean, the reality is I would always, this is a huge upgrade for me because I would still
Mhm.
always have to search down here and I'd
Yeah, I
search up
agree.
here, right? So this is so much better to give me the relevant information quickly there. That's been a huge upgrade.
Yeah. So we're looking at from a, statistics and what is higher risk. We're looking at two values, the B wave, which, we have A wave, you have the B wave. We're looking at that amplitude right before it's going to now start to measure the PHNR and what's called the W ratio, which again, like the diabetic or the DR score, has some calculations to it that thank goodness we don't have to do in our heads. It is done for us, but it essentially is taking into account information about the B wave, information about the PHNR, and putting that together with a value that's going to tell us if somebody's ganglion cell function is decreasing over time. So again, B wave above 89% or the W ratio less than 11%, that is when we should be concerned and that there is likely some damage to the ganglion cell layer we need to pay attention to. And does that match our OCT findings or visual field? Is that the one other piece that, yeah, there's progression and there's concern here that I'm going to start them on this eye drop that often once we go down this road, this is a lifetime road that we're going. You don't see a lot of people get taken off of eye drops unless they're, pursuing some other kind of intervention. So to me, initiating glaucoma treatment's a big deal because you are going to be talking about this for life, and then we have all consequences of the eye drops and ocular surface and, et cetera. So I find it a big deal discussion, and having this one more piece of information extremely helpful for me to make those decisions.
For sure.
Forward. Yep. So yeah, now the tricky thing with using it for glaucoma in particular is that you can't use it for the glaucoma codes. You can't use it as a glaucoma suspect. Most commonly I'm probably using the glaucomatous optic atrophy. If someone has any kind of nerve cupping, it's asymmetric from one eye to the other. It has vertical elongation. It doesn't follow the isn't rule. I'm seeing progression over time. There's, thinning that I'm catching on the OCT that I've done. To me, any of those findings is some type of glaucomatous optic atrophy. So I feel very comfortable using that code often. Now, the really tricky ones that maybe you're walking a line I don't always feel comfortable are these people who have like 28 eye pressures and 0.2 cups and everything is perfect. So it is a little bit tricky. You got to think about what you're going to code and how you're going to use it. But I use it on the majority of my glaucoma patients with that code.
And listen, the reality
yeah.
to that point, Amanda, is like, you're going to find a lot of patients that will fall into one of these buckets. But if you don't, right, don't fudge it. The reality is you just tell the patient, listen, I don't think your insurance is going to cover this. I think it's a really important test. That means that if you like this test, you can pay for it out of pocket. And we'll submit it to your insurance with the codes that we have. But if they don't pay for it, it's still your responsibility, right? That's the way an ABN is working. We don't have to feel like bad about it. If they say no, I don't want this test, great. Then I have to do what I have to do. I have to take care of you the way that you're letting me take care of you. And as well as I do that's part of patient preference for treatment or for testing.
I love putting that out there. Just because it's not covered doesn't mean you can't do the test. Absolutely.
For sure. Well, Amanda, that was awesome. That was a whirlwind of information. I don't think we thought that. I didn't think that we were going to get through all that information. You did a great job. Thanks for doing this with me. I think I want to be respectful
but I'd be
of
happy to
everybody's
answer
time.
questions and such.
For sure. Yeah. So I'll say this, and then maybe we'll open it up for a few minutes for questions. There's a couple different last pieces. If you're thinking about integrating these in any of the ways that we've talked about tonight, both on case studies or how am I going to incorporate this into your practice? Actually, we've developed a course that is free to anybody. You take a coupon, you take a picture of this, use that coupon code. It'll be free to you to access. And really what we try to do is what Amanda and I have been talking about is we've been talking about figuring out where this fits for your patients first. What patients do you want to use this on? What information are you going to get that's going to allow you to have the potential to make different decisions on how you're going to manage that patient, or different ways to communicate with them and help them through their disease state and improve their quality of life. That's what this course helps you do, is it allows you to customize your path based on the way that you want to manage your patients. Because, the reality is Amanda and I have really deeply held beliefs about our role in our communities. I think it's absolutely, when I listen to Amanda, I know that's true when I listen to her. And so we can tell you all the things that we do. And that's, I think, really relevant when she's telling me what I should, or what she does. I think, oh, I'm going to do that. But what you have to do is we find that when you actually incorporate new technology into your practice, you have to own it and you have to build it yourself. And that's what this course is for. I'll leave you with that. Any questions that have come up for Amanda or for me? And thanks everybody for jumping on tonight. We really appreciate it.
Yeah, thanks. That was great.
Any questions that have come up in the chat?
We do not have any questions in the chat right now.
Wow.
We taught them everything
Amanda,
about ERG.
Great job. All right. Awesome. Well, thanks everybody for jumping on. Amanda, thanks for joining me. This has been great. A lot of fun.
Pleasure as always.